Good day, everyone. I am Visahi Sivamar. Um, Welcome to my ERPM online classes. I graduated from University of Sri Jayavarthanapura BPS degree recently, and this is my free session, online session, so that you can decide whether to proceed with my classes. So I thought of doing pediatrics today. For the pediatrics, today I'm going to discuss on the growth of children, because for the pediatrics MCQs, you will definitely get one true or false MCQ in growth of children. It's a definite MCQ. So you should be thorough with that, so that you can correctly score that MCQ. Okay, let's start. Normal growth in children. Growth is common to all living beings. So growth occurs with hyperplasia, hypertrophy, differentiation. So it results in increased height and weight, body composition changes, maturation in the all structures in human beings. So growth, if the factors that differs pediatrics from adult medicine is growth, because its growth starts actually from the zygote fetal growth, and it's one of these zygote and fetal growth phase is one of the most rapid phase of growth in human beings. Okay, then fetal growth. When we see about fetal growth, it usually assessed by ultrasound scan when the mother is pregnant, and this is rapid growth occur during this period. Usually in MCQs, they give stems like rapid growth occurs in adults, like that. That is false statement, because rapid growth occur during fetal stage. Okay, within 10 months from one cell, organism is made within 10 months. So that's a rapid growth phase of human being. Okay. This fetal growth is assessed by crown heel or crown drum length, where it means head to heel length, which is standing height in when the mother is pregnant, and crown drum length mean top of the head to bottom of the buttocks. Means a sitting height. Okay. Compared these fetal growth is compared using, we usually discuss this about FGR, UGR, and Genenops. So they won't ask much about fetal growth in pediatrics, but for the time being, compared using distance charts, velocity chart. Distance charts means it's a weight, height recording charts, and velocity charts mean weight, height, gain record charts. They won't ask this in your exams. And the peak length velocity occurs during 18 to 22 weeks in uterus. Okay, in utero. So this is a peak length velocity. This can be asked in MCQ. The peak weight velocity occur at 34 weeks. So the length of the baby grows at its peak during 18 to 22 weeks, but the weight of the baby increases at its peak during 34 weeks in utero. Okay, this is a distant chart of crown heel length and crown heel velocity chart. They won't ask this in the cases. They will not ask. Okay, during last few weeks of pregnancy, the weight gain increases. The weight gain of the baby increases, but though the weight increases, the height will not increase because of the restriction given by the uterus on growth, and also the placenta cannot support. So due to these things, the height won't increase in the latter part of the pregnancy, but the weight gain increases. After birth, there is a rapid catch-up, the rapid growth due to catch-up, because the child will be taking food, the breast milk, and after birth, the rapid growth occurs. Okay. The factors that affect the birth weight or the birth length. Here you have to study the birth weight and length, not the weight gain after birth. It's about the factors affecting birth weight and the length. These are assessed in MCQs because you have to be keen whether the question is based on birth weight or the birth gain after birth. So sorry, weight gain after birth. The birth weight or birth length means the length or the weight at which the child is, the neonate is at birth. Okay, this is depends on birth order. That means if it is the first baby, usually first baby weight height will be, birth weight height will be lower than the consequent babies in birth order. That also depends. And the height of the mother. Remember, height of the father will not affect the birth weight or birth length. Because if the height of the father affects the birth weight or birth length, usually a short mother can't accommodate a lengthier baby. No, that's why the height of the father will not affect the birth weight or birth length. These are common MCQs asking growth. So, but the height of the mother affects the birth weight and birth length. Okay, weight gain during the pregnancy and nutrition before and during the pregnancy. That's why the anemia, all those nutrition deficiencies are corrected. Folic acid is corrected so that the birth weight and length of the baby won't be affected. Nutrition before and during the pregnancy, smoking and alcohol of mother, genetics. Genetics mean especially the genetics of mother, because genetics of father will not affect the birth weight, but it will affect the ultimate weight and length of the baby. And length of the human, because if the father is high, the child will be taller, like that. But at the birth, it won't affect. That's the difference. So carefully read your question. Okay. Maternal illness. If the mother is having pregnancy-induced hypertension, diabetic mellitus during pregnancy, or if there is an intrauterine illness for the baby, those things will affect the birth weight or birth length of the baby. Okay. And these are common MCQ points. And regulation of prenatal growth. What is prenatal? Prenatal mean it's the growth of the baby in utero. Okay, it's not after birth. It's before birth. The regulation. Okay, these also important area. The IGF-1 and IGF-2, these are fetal growth. The main regulatory factors of fetal growth is IGF-1 and IGF-2. This insulin-like growth factor 1 and 2. They are the two main growth factors in prenatal growth. So they share 50% of homology with insulin, because they are 50%, their structure is alike insulin. They are like insulin, 50%. And IGF, they bind to insulin receptors with low affinity. And IGF receptors, there are two type of IGF receptors. Usually they don't ask these things in MCQs, but you should know that IGF-1 and 2 are main regulatory factors in prenatal growth. Okay, there are two IGF receptors, type 1 and type 2. Type 1 have high insulin concentration. They at high insulin concentration, they can bind. Both IGF-1 and IGF-2 binds to type 1 IGF receptor. And IGF-2 binds with high affinity, but IGF-1 will affect with low affinity with type 2 receptor. And insulin will not bind with type 2 receptor. These are don't bother about these things, but remember, IGF-1 and IGF-2 are important for prenatal growth. Okay. If the mother is diabetic, there will be high sugar level in baby also, because all the glucose from the mother will be transferred, the part of the glucose will be transferred to the mother. So if the mother have, usually if a normal mother have 100 glucose, let's say 30 is transferred, 30% is transferred to the baby. If the mother has 200 glucose, 60 will be transferred. So the amount will be high if mother has high glucose level in the baby. This will lead to high insulin level. You all know that if sugar glucose level increases, to reduce that, insulin also increases. So in babies born to diabetic mother, the insulin levels also increases because the baby will be having high glucose level. So insulin will be binding to this IGF receptor 1, and they stimulate the growth. This insulin has the potential to stimulate prenatal growth in children, in utero babies. So this insulin will increase due to high glucose level, and it stimulate the growth, and the babies will be larger when they are born. That's why I previously said intrauterine illness, mother's illness will affect the birth weight and birth height of the baby. Okay. So that's why the macrosomic baby is born to GDM, diabetic mothers. Okay. And there are some other growth factors. They won't ask this, but for time being, you can study if you have interest. Fibroblast growth factors, epidermal growth factors, transforming growth factors, platelet-derived growth factors, nerve growth factors. There are so many growth factors, but the important growth factors in prenatal growth is IGF-1 and IGF-2. These growth factors stimulate DNA synthesis and mitogenesis in cell cycle. You don't need to know about these things for the ERPM exams. Okay. Postnatal growth. Postnatal means after birth. After birth, it will depend on other factors. So when you're talking about growth, you have to know at which age, which substance, which chemical is affecting the growth. That will be tested in your MCQs. Okay. First 2 years of growth after birth, for first 2 years of growth, it's a quite rapid, but decelerating. Okay. It won't be much rapid like second, third trimester, but still it's a rapid phase, but decelerating phase. Okay. The fastest growth happen in utero during second, third trimester. So these are MCQ points. So the fastest growth always happen in utero, not after birth. Okay. But still, first 2 years of birth, it's the rapid growth. It's a phase where rapid growth happening after birth. Okay. After birth, the rapid growth happens within first 2 years. But in our lifespan, in the human lifespan, the fastest growth phase is the in utero phase, which is first, second trimester and third trimester. For first 2 years, the main growth-related disorders are shown up. If the child is having any growth-related disorders which were masked during in utero period, they will be shown in first 2 years. Predominantly, when there is a growth-related disorders shown at first 2 years, those are commonly nutritional dependent growth-related disorders. Okay, nutritional dependent. And there are two main patterns you can see during first 2 years. Those are noted in CHDR, because you might not be knowing about CHDR because it's used in Sri Lankan setup. CHDR mean Child Health Development Record. You should be thorough with CHDR to pass your pediatric, because definitely you will get MCQs and definitely they will ask at the cases as well. Okay. This is a photo of I got from CHDR, and in the CHDR there are graphs for the birth, for the weight gain, for the height gain, and for the BMI. There are charts from birth till 19 years of age. There are graphs in CHDR about the growth. Okay, so in CHDR there are, you should be thorough with some of the terms used in CHDR and pediatric medicine. Okay, that's it. There is a two main pattern. It means catch up growth and catch down growth. For all these postnatal growth, a proper feeding, nutritional feeding is needed, because mostly first 2 years is more dependent on the child's nutritional level. Okay. Catch up means the reduced growth in last few weeks of fetal life will be catched up. This is catch up in the first graph. Catch up mean increasing. Usually, after birth, the birth weight decreases, and again the weight increases, and again the baby will come to birth weight in 2 weeks' time. It will increase and decrease. It means um, if the child is 2.5 kg at birth, and within 2 weeks of period, within 2 weeks, the child weight will be decreasing and it will increase, and at 2 weeks the child will again get his birth weight gain, 2.5 kg. So at 2 weeks the child will be at birth weight, which is quite normal. Okay, it will slowly decrease and slowly increase, and ultimately after 2 weeks the child will be returned to its birth weight. Then only the after 2 weeks only the birth weight will increase. The graph will go like this. Okay, that is known as catch up growth. Catch up means his birth weight reduced, and somewhat the baby managed to catch up his birth weight again in 2 weeks. That's the meaning of catch up growth. Then the catch down growth. Catch down growth means if the mother had diabetic mellitus, diabetic during pregnancy, and the child will be macrosomic baby. It means it will be more than the weight of the normal birth weight range. Okay, the normal birth weight range usually between 2.5 to 3.5 kg. The child will be more than 3.5 kg at birth, which is not normal. Okay, so for that, during these 2 weeks time, the child's weight will decrease and child weight will increase, but it will not attain the birth weight, which was a abnormal weight at birth. Example, the baby born to diabetic mother at 4 kg. The birth weight of the baby was 4 kg. So after 2 weeks, the baby will be at 2.5 kg. This is an example. This is not an exact thing. That the baby will be at 2.5 kg, which is quite normal, because usually 2.5 kg is a normal birth weight. So ultimately, after 2 weeks, the baby will return to normal birth weight. This is the catch down growth, because it reduced the baby reduced its birth weight, and ultimately after 2 weeks it came to the normal birth weight level. Okay, this is known as catch down growth. You should be thorough with catch up growth and catch down growth. These are important. Usually catch down growth growth happens in babies born to diabetic mothers or any macrosomic babies. Okay, catch up growth happens in normal babies, normal birth weight babies. Okay, after it settles down to its own centile around 2 to 3 months, because it will take some time for the baby to come to a normal centile chart. Okay, centiles mean in this CHDR. I will be giving you the CHDRs. I will be explaining about CHDR in the future sessions. And these are the centile graphs. These lines are centiles. Okay, there are you will be having your CHDR at home, asked from your mother. If you are the Sri Lankan, if you're born in Sri Lanka, and these are the centile graphs. A normal child have to follow these centile charts. It should the growth of the child, the weight, height, all should be parallel to these centile charts, centile graphs. Okay, it should be parallel. When you plot like this, the every monthly or weekly weight of the child, if you connect these lines, you will get a graph of the child. These graph should be parallel to the standard centile charts. So after birth, for first 2 to 3 months, there will be some irregularities in the chart, in the growth of the baby, and it will come to the normal centile pattern around 2 to 3 months. Also, there may have been problems with the placenta, bicondylar uterus, all those things. Due to those things, the baby will take 2 to 3 months to come to a normal pattern. That's normal. Okay. And the next important thing is the phases. These are frequently asked in MCQs. The 3 phases of postnatal growth after birth. Postnatal mean after birth, you all know. The first one is infancy and early childhood. It's up to 3 years. We see in Sri Lanka up to 3 years. It's infancy and early childhood. During infancy and early childhood, the growth is mainly dependent on nutrition the child gets. So the nutrition, the breastfeeding, the complementary feeding, all those things, the growth is depended on the nutrition mainly, and also thyroxine. There's a thyroxine hormone. If the child is having hypothyroidism or congenital hypothyroidism, it will affect the birth, and it will affect the growth of the baby. And for first 3 years, thyroxine as well as nutrition, these two things are important for first 3 year growth. Then during childhood, the growth hormone is the thing which affects the growth of the baby. Rather than nutrition or thyroxine level, it's a growth hormone, which is the main thing that affect the childhood growth. During puberty, sex hormone is the thing which mainly affects the growth after puberty. Okay, so this is the frequently asked MCQ points, because the stem will come like sex hormone dependent growth happens during childhood. This is a false statement, because the growth hormone dependent growth happens during childhood. Sex hormone dependent growth will happen during puberty, and nutrition and thyroxine dependent growth will happen during infancy and early childhood. This is the most important area you should know. Okay. And during in human life, there are 2 peaks of growth, we would say. The first peak would be in utero, and the second peak of growth will be during puberty. There will be 2 peaks in height, usually the height. Okay, in utero, and then the next peak will be during puberty. Then the growth after some years after puberty, we won't grow. It means we will gain weight, but we won't grow tall after puberty due to closure of our bone epiphyseal plates. We won't grow taller. So there our height development stops a few years after puberty. Growth during adolescence. Okay. This is an important MCQ point. That means the pre-pubertal growth. Pre-pubertal mean before puberty, our limbs will grow faster than our trunk. Which are trunk? Which is the trunk? Which is the limb? Limb means our legs, and the trunk means our torso, our body, our spinal cord, our body. Okay. So our thorax, abdomen, our upper body. So during pre-pubertal age, our limbs will be lengthier than the upper body. The lower body will be lengthier than the upper body, because the limbs will be growing faster during pre-pubertal growth. But after puberty, during puberty, our trunk will grow faster and taller. Okay, so before puberty, limbs limbs grow faster and they become lengthier. And during puberty, the trunk grows faster and it will be lengthier. So here, this is a common MCQ point, and here you should be thorough whether the MCQs ask on pre-pubertal or during puberty. In puberty, the changes occur in the size, shape, body composition. Body composition mainly depends. Body composition means your fat content will increase in females so that to provide energy for the reproduction. Reproduction is the ultimate goal of a human. So for the growth, the ultimate goal is to attain a good reproductive maturity. So for that only, a growth is happening in human. So body composition changes. The onset of puberty, especially the menarche, the first menstruation, is the onset of puberty in girls. Onset of puberty, especially menarche, is related to nutrition. So nutrition is the main dependent for the onset of puberty. It means onset of menarche. If the child is intaking more and more fat during his childhood, he will attain menarche at the early stage. If the fat content is less and the baby, where the child is taking only the nutritious food or proteins or less nutritious food, like that, it will be delayed. So the onset of puberty, especially the menarche, is related to nutrition. These are MCQ points. And obesity will lead to early menarche. Obesity, I initially said, obesity means that if the child is taking more fat, the child will be obese and he will attain menarche early. Because for the obesity, the leptin level will increase when the fat content increase in our body. Leptin means fat. So it acts on hypothalamus and it stimulates pulsatile secretion of GnRH level, which induce the menarche, early menarche. But they won't ask this leptin level or those things. But you should know that nutritional level changes the onset of puberty, especially menarche. Then the adolescent growth spurt. During adolescence, the peak height velocity occurs in males at 10 centimeter per year, which a standard deviation is 1 centimeter per year. And in females, 9 centimeter per year, they grow. This is the peak height velocity. And usually this would be a MCQ stem, true or false stem, just in females, peak velocity 10 centimeter per year. That's wrong because it's 9 centimeter per year, like that. The peak height velocity occurs for males at 14 years of age and for females 12 years of age. And because in your classes, in your school days, you might you have seen that boys are shorter than you before grade 7 or 8, and after grade 9, grade 10, they will be suddenly they will catch up way height, and the boys will become very tall. So that's the thing. That's the thing mentioned here. This is also MCQ point. For male, 14 years, and for females, 12 years, the peak height velocity. These are the things that we say in Sri Lankan setup, because this is for Sri Lankan, so it means Asians. This might be wrong in other countries, but for our MCQ purpose, our exam paper purpose, this is the thing. For males 14 years, females 12 years, peak height velocity. Changes in body composition, the muscle, fat mass, all those things will changes, bone mineral density, total body weight, and the RBC level, hemoglobin level, all those things, everything in the body will be changed when the child growth. Okay, effects of bone age on growth. Bone age is an important thing. in growth. And if a child is having short stature, this usually I will be discussing about short stature in the future sessions. Future in the short stature as well, the bone age is very important. It's a limiting factor on linear growth. Linear growth means the height. The bone age is the limiting factor in your height or linear growth. This is the MCQ point. The estrogen is the limiting factor, actually, the bone growth in both male and female. Estrogen is the hormone which limits the height of a human. In males, from aromatization of testosterone, estrogen is produced. In females, from ovaries, estrogen is produced. Don't think if only girls have estrogen, boys also have estrogen, which is produced from testosterone. The bone's epiphyseal closure, usually long bones, have this epiphyseal plate. This epiphyseal plate, if the epiphyseal plate is closed, it won't grow lengthy. The bone won't grow lengthy. So bone epiphyseal closure, it's done by estrogen, which limits the height or the linear growth of a child. So after puberty, as estrogen is secreted more at puberty, the epiphyseal plate starts to close, and the height of the baby, height of the child, will not increase once the epiphyseal plates closed. These are the curves, growth curves in different tissues, because from tissue to tissues, the growth curves differs, but you don't need to know everything because these won't be checked in your exams. You can refer this chart if you want. Usually, our head will not go on growing for after 2 or 3 years. If head will keep on growing, we will be having a massive head. So like that, every organ differs in their growth, every organs, but they won't ask this in exams. So lymphoid maturation, lymphoid tissues, you all know lymphocytes, lymphoid tissues occurs when child faces infection and develops immunity. So it's late, it will take time. The lymphoids take time to develop, because if a child if the child is exposed to any infection only, the lymphoid maturation occurs. If your parenting style is different and the child is grown overprotective wise, child won't get good immunity. So it's a hygiene hypothesis theory. We all study, you all know hygiene hypothesis theory, which is usually discussing when we would discuss in asthma. If the child is um, looked after very in an overprotective manner, the child won't get immunity, because he won't be able to face any infections due to parenting pattern. Okay, catch-up growth and growth regulation. This growth will take in the inherent curve. Inherent mean your genetic curve. If all other factors are supplied, your nutrition, your hormones, all those factors are supplied properly, then the growth will take a pattern of the genetics. If both your if the both parents are very short, we can't expect the child to grow taller, because that's an inherent curve, genetic curve. According to genetics, the child will be short. If all the nutrients are supplied properly, nutritional hormones, then only the child growth will follow the genetics. If there is a nutritional deficiency, if a child is born to a taller parents, but the child is having nutritional deficiencies, still the child won't attain the height of the parents, because child is having nutritional deficiencies. So all the factors should be supplied in an adequate manner. Then only the genetic pattern will be followed. There could be a drop in the curve due to an acute insult. If there's an acute insult, the usually acute insult mean infection, a famine, any infection to the baby, uh, the weight will acutely drop. For example, if a 1 year child who is eating properly and who is at adequate weight gain, if the child develops fever for 1 week duration, during that time the child won't eat properly, so the weight will reduce. So there could be drop in the weight gain chart if there's any acute insult like infection. But after correction, it means after correction means if the infection is resolved and child is now eating properly, but after correction, they will get a catch up. Here, the catch up word is used. Catch up means the child will return to its normal weight. Okay. Catch up growth and fall in the original line. So it's important to provide optimum adequate nutrition for any child. Okay, here there are premature babies as well. What's prematurity? It's usually a preterm baby, baby born before 37 weeks gestation. If the child is born before 37 weeks, in CHDR for first 2 years, there are different charts for premature baby as well as term baby. There are different charts for preterm babies and term babies. You should know all those things before going to the pediatrics and gynocs exams. The baby, there are in CHDR graph, there are red zone, yellow zone, green zone, like that. If the baby is in red zone means this red line, this red area, red zone, but it's good that baby has regularly increasing height or weight. That's enough. It means uh, still here, D is the baby. The baby is in red zone. Red zone is actually inadequate weight. But in premature baby, if still the baby is growing in the same pattern, and it means parallel to the centile. These are the centile lines. If the growth is parallel to the centile line, that's okay because this is already a premature baby. We can't expect fastest growth like term baby in a premature baby. It will take time. The baby will take time to catch up growth. So even if the baby is in red zone in the CHDR graph, but still the centile, the growth, the weight gain, the height gain is parallel to the centile graph, still that's okay. Okay. Without any fluctuation. But if it is a preterm or term baby in this graph, preterm, there are different five ABCD five graphs for the to explain you all about different kinds of growth the child may be facing. Okay, in this graph, D is the previous child I told, the premature baby, but still the height, the growth gain is going parallel to the this centile graph. So it's okay. So D is okay. C is another child, still a premature baby or term baby, that's okay. Still another child. The growth is increasing and it's in yellow line, and it's also keep on increasing and it's still parallel to the centile line. This is a centile line, green, yellow centile line. Still, this line is parallel to the centile line. So C also okay. But it A also that he's in green area. This is a green area. A is in green area and he's keep on increasing, and it's also parallel to the again to the this centile line. This is centile line. Still, it's parallel to the centile line. So A also okay. But in case of B and E, there is fluctuations. It means initially for the E, see the graph of the E. In the E, initially the growth is okay. It's parallel. Then afterwards, there is fluctuation. The growth has reduced and it's not parallel to the previous centile line. Okay. So there's a fluctuation. So acute somewhere there's during this period an insult has been happened. It could be a nutritional deficiency or any infection or any disease has happened, and the weight of the baby has reduced, and again the baby somewhat managed to gain his previous original normal centile pattern. Okay, during this period, the child has faced the fluctuation, so this is not normal. In B also, the centile chart was started normally, and it has changed. Whether it's increased or decreased, that's not a matter. It has changed. So when the centile pattern is changing, whether it's increasing or decreasing, but still whether it's if it is changing, we have to address the problem, because uh, there could be a deficiency, or there could be an overfeeding or obesity like pattern. So we have to address those things. So you should be thorough with these graphs and thoroughly study them. It's important to see the trend. This is a trend. This graph going direction. This is known as a trend. See the trend in growth before making a comment. They won't give the CHDR and ask to comment, but they will not do in cases they won't give CHDR. But for MCQs, definitely one question will be on CHDR and growth, and mm, some sometimes you will get cases like malnutrition, severe acute malnutrition, moderate acute malnutrition. Your child, you will be getting cases. uh, for if you get SAM or MAM cases, severe acute malnutrition SAM cases, you will be asked about these graphs. Okay, it's important to see the trend in growth before making a comment. Just being overweight or underweight at the moment doesn't say baby has a problem. Now the baby is overweight, now the baby is underweight, but we can't say that baby has a problem. We have to follow the trend. At least we should know the 3 4 months growth pattern to say whether it's actually overweight or actually underweight. Okay, at the moment we can't say. With one reading we can't say overweight or underweight. We have to follow the graph trend. Doesn't say baby has problem. Also, just having normal weight or height doesn't say baby is healthy. Okay, the weight gain or height gain is normal. We can't say that the baby is normal with one reading. We have to follow the baby for 3 to 4 months at least, and we have to um, identify the trend of how the baby is growing, and then only we can comment. Okay, with one reading, we can't say whether it's normal weight, underweight, or overweight. Okay, these are the graphs. I have just put them in the CHDR. At 5 months, growth declining and start on complementary feeding, because here is an example of a baby. Here you see there's the baby is going at a normal centile, and suddenly at 6 months of age, for this baby it's 4 to 6 months, it's not clear in this picture. At 4 to 6 months there's a sudden drop. There's a difference in the previous pattern from the previous pattern. This could be because of start of complementary feeding, because for past for 6 months the child was on complementary exclusive breast milk, and now the child is changed to complementary feeding, which is new to the child. And initially the child won't take much food, and his digestive system have to get mature to absorb all those nutrients. So due to that, and during the short period after starting of complementary feeding, there will be uh, uh, changes in the previous growth trend. And again, after if the child is okay with that complementary feeding pattern, it will catch up growth again. Okay, that's a difference. And afterwards, there are some terms you should be thorough with. Those terms are faltering, flattening, weight drop, catch up growth. These are the things we use when commenting on the CHDR graphs. Okay. First one is faltering. Faltering growth means here faltering. It's reducing. This is a graph. Here. Here is the graph. This blue color graph. This graph. Okay. This is a faltering growth. Faltering means initially child is increasing and is parallel to the centile line. Then the direction has changed and it has reduced. Then because the energy supplied to the child, because the energy supplied by nutrition, this energy is not enough. So the child's growth pattern has faltered. It's a faltering. Energy is not enough, so it has dropped. So not enough food, or there could be underlying infection or any underlying illness, any feeding difficulties or underlying illness. Because of that, there is energy, inadequate energy, and the child's growth is faltering. This is faltering. And the next one is flattening. You should know what's the cause for faltering, flattening, weight drop, catch up growth, all those things. Usually for faltering, not enough food or underlying any illness is the cause for faltering growth. Next one is flattening. Flattening means here this maroon color graph. Flattening means after 2 to 3 months, if this faltering, first one is faltering, if the faltering um, uh, is not corrected and there is no growth still, this is called flattening. It means flat. Okay, it means uh, from one from first stage, after correction, the graph should go like this. If it's corrected properly, the graph should grow in this manner. But the graph has not attained to the normal or the previous pattern. It has still dropping, or it's flattening. There is no growth at all. Uh, because the problems faced during faltering growth has not addressed or has not corrected. Because of that, the child is not growing now. Okay, this is the flattening. This is due to the inadequate correction of faltering growth. Faltering means the pattern, the normal pattern. This should be a normal pattern, for example, but this normal pattern has deviated and child is growing slowly. This is a falter. But flattening, at this point, the faltering growth should be corrected, but it was not corrected properly, and still the child growth, it's not slow, it has stopped. The child is not growing, still the same height and weight for some duration. This is flattening. Okay, the growth, if the growth has slowed down, faltering growth. If the child is not growing, that's flattening growth. This is the difference. The weight drop means reduction in the weight. Here there's a sudden reduction in the weight. It could be due to any illness or uh, any underlying illness, like problems in swallowing, like that. There will be a sudden weight drop. This is a weight drop. This is a easy thing. And catch up growth, as I said before, it's catch up means after weight drop, a child again come to its normal pattern. This is catch up growth. Okay, difficult to achieve, underlying problem has been corrected. If the problem is corrected, the child will catch up its normal growth pattern. If the problem is not corrected properly, the child won't attain the normal pattern, and that's called flattening. So you should be thorough with all 4 terms. Okay, this will be asked in MCQs. The parameters of growth, these are there in CHDR: weight, height, mid-arm circumference, skin fold thickness, OFC, or means occipital frontal circumference, waist circumference. These are checked and noted, plotted in CHDR. To weigh the child in Sri Lankan setup, spring balance is used. There are bathroom scales, hanging balance. Hanging balance. These are hanging balance. Here, there's a swing-like thing. You can see in our MOH office. Hanging balance is used for the babies who are grown, so that they cannot be put in cradle balance. This is a cradle balance. This is the cradle balance. Cradle balance is used if the baby can't sit. If the baby can't sit, we measure the weight of the baby in the cradle balance. Okay. If the baby can sit, or if the baby cannot be weighed using cradle balance, we get the weight of the baby using hanging balance. This is a hanging balance. And then the cradle type is usually for infants. Bathroom scales, as you all know, that standing, if you stand, is the bathroom balance, we say. This is term we use in Sri Lanka. You have to know that, because there could be many terms, but the standard terms are hanging balance. This is a hanging balance. This is a bathroom scale, and this is a cradle balance. Okay. And we should calibrate the instruments first. Before measuring any instrument, we should calibrate at least once a week. In the MOH setup, they should calibrate the instruments in once a week at least. Otherwise, they will over-record the measurements. Okay. The spring balance, the bottom scale, hanging scale, cradle type. For beam balance, they are platform type and cradle type. Beam balance, they won't ask about beam balance. They will ask about spring balance. Okay, when weighing the child, we should put them on minimal clothes. We should remove all the clothes, because the weight of the clothes will be added, no? So we can't get the actual weight of the baby. Put them on minimal clothes. Don't measure the weight of the crying or shouting baby. If the baby is shouting or crying, first we have to calm the child. Then only we can measure the weight. Otherwise, the measurements will be wrong. And if the child is keep on crying, we can measure the weight of the mother, and we can measure the weight of the baby and mother. When the mother is holding the baby, then we can subtract and calculate the body weight. These are things important in your daily pediatric practice when you are practicing as a house officer. This won't be asked in exams, but it's important for the practice if the child is crying. Okay, this is a cradle type. This is a cradle type balance. Okay. Okay. This is for the weight. And then for the height. For the height, to measure the height, infantiometer. Yeah. Practice to these terms, because you will be new to these terms. This is the infantiometer. Infantiometer means it's used to measure the length of the baby, not the height. Because if the baby can't stand, usually height is measured when the baby is standing or when the child is standing. So if the baby can't stand, the length is measured using infantiometer. This is the infantiometer. Okay, baby is placed on the infantiometer, and the head end and the foot end is measured, and length of the baby is got. An infantiometer is horizontally placed, measured in both in the foot end will be moved. The foot end can be moved. This is a foot end. This is the foot end. This foot end can be moved. This is a head end. We place the head at the head end, and we place the baby, and we move this foot end, and we measure the length of the baby. Okay. These are things you need for the clinical practice, but they won't ask these things in exam. But you should know that the infantiometer is used to measure the length of the baby. Horizontal place and foot end can be moved. Head is kept at the fixed end. So when measuring when measuring the length or the length of the child, 5 points 5 points have to touch the infantiometer. Those 5 points are the baby's back of the heel, the calves of the baby, buttocks, back of the chest, and occiput. These 5 things should be touching the infantiometer at the same time. Then only we will be getting the accurate length of the baby. Okay, should be touching the horizontal surface of the infantiometer at the same time. Then the half height measurement, if the for the length, if the child is less than 2 years, we use infantometer because the child can't stand. For the height, because more than 2 year child can stand, for that baby, we use stadiometer. This is a stadiometer, the standing length. This is a stadiometer. Stadiometer. The height of the baby can be got. Okay. And when measuring the height as well, the 5 points should be touching. What are the 5 points? The 5 points are here. It's known as the Frankfurt plane. You have to see whether these 5 points are touching the stadiometer or not. It means that again the heel of the child, the calf of the child, the buttocks prominence, and the back of the chest, and the occiput. For both, when measuring length and height, these 5 points have to be in touch with the measuring instrument. Then only you will get the accurate length or height. When measuring the height, the child is requested to remove the footwear, hair ornaments, because it will give the false reading. And the child should be relaxed, keeping both hands either side of the body. Keep looking. The child should looking straight. Measure them. Measurer, then bring down the head, brought down. You would have seen measuring in stadiometer in your clinical practice. Touch the most superior part of the head, the height to be nearest 1 millimeter. They won't ask how to measure, but you should know the 5 points which has to be touched when measuring. In infancy, the height is checked more frequently. Then afterwards, the height is checked once in 6 months. That's enough. This is the MCQ point. Like this, the stem will have appear like where height is checked once in a month in a child. That's wrong. Height is checked once in 6 months. Okay. This is a Frankfurt plane, which is the same horizontal plane, which tells about the 5 points touching the vertical surface, as I mentioned before. Then the next thing is occipitofrontal circumference. You'll know we measure the OFC of child. OFC is usually measured up to 3 years in Sri Lanka because we have graphs up to 3 years in CHDR for OFC measurement. This is a mainly important, valuable in partial syntosis-like conditions, and for that we measure it properly. Okay, then for the children, again, for the children and adolescents, waist circumference has importance when we are addressing for obesity like things. Waist circumference should be more than 90th centile to the relevant of age sex is a feature of metabolic syndrome. It shouldn't be more than 90th centile. If the waist circumference is, this is the waist circumference and this is the hip. Okay, don't confuse yourself. Waist is different from hip circumference. So when reading the MCQ stand, look whether waist is given or hips is given. Actually, we look for waist circumference, not the hip circumference. Waist circumference should be more than 90th centile to relevant age. If it is more than 90th centile for age or sex, it's a feature of metabolic syndrome. Okay, this is a MCQ point. Usually waist circumference is measured like this, and hip circumference, they won't ask how to measure waist or hip circumference, but waist circumference is the important thing. So if the waist circumference is more than 90 centile, to confirm whether it's metabolic syndrome or not, we have to look at the waist hip ratio. For that, we have to measure the waist circumference as well as hip circumference. Okay, this is an MCQ point. MCQ will appear as like example, waist circumference confirms metabolic syndrome. This wrong, because waist circumference only suggests whether it could be a metabolic syndrome. To confirm it, to confirm the metabolic syndrome, we have to look at the waist to hip ratio. Without the waist to hip ratio, we can't say whether it's metabolic syndrome or not. But with waist circumference, we can suspect whether the child is having metabolic syndrome or not. Okay, be clear on that. If you have any doubts, you can ask me WhatsApp. Okay, then the body mass index, BMI calculator, you all know, weight over height square, weight in kilogram and height in meters. And then weight to height ratio, there's, okay. Okay, the next important thing is OFC. When measuring OFC, some of the points, these things can be assessed in your cases, because if you are given a child less than 2 years, and in examination, you have to measure OFC and you have to show that because it's observed cases. So for that, practice measuring OFC. Occipital-frontal circumference, OFC, measured in children under 2 years in Sri Lanka. The child sits on mother's lap because the child won't be cooperative. So for that reason, we place a child on mother's lap, and measurer stays on the left side. Don't stay at the right side, because for all our other exam purpose, we stand at the right side of the patient, but to measure the OFC, it's easier to stand at the left side. So it stays the left side and take the measurement. Tape should be like just above the eyebrow of the child. This is the main thing, and over the occipital protuberance in the back. You know, in this child, this over the eyebrow front, and in the back, it's above the occipital protuberance. Okay, that's a correct method to measure the OFC over the occipital protuberance in the back. Tape should be tight enough to compress any hair caught in between, and the mid. That's how we measure the OFC. And then the mid upper arm circumference. This is another important measurement, because for children between 1 to 5 years, for rapid screening of undernutrition, we use mid upper arm circumference. This is an MCQ point. This is used for screening purpose. It's not a confirming investigation or confirming examination. It's just used as a rapid screening method. Rapid screening is used if there are more children, like in schools or in a village. If you are screening for undernutrition, then you will use mid-upper arm circumference. If there's a stem like mid-upper arm circumference is used for confirming undernutrition, that statement is wrong, because it's used only for screening purpose. Okay, there are color codes is mid arm circumference strip, which is known as Sharkey strip. You should be thorough with this. You should know what's the name of the instrument. It's a Sharkey strip we used in Sri Lanka to measure the mid arm circumference. Okay, for children between 1 to 5 years for rapid screening of undernutrition, we use mid upper arm circumference. There are color codes. If it is in red color, it means the arm circumference is less than 11.5 centimeter. This is SAM, severe acute malnutrition. So undernutrition. If it is yellow, in yellow color, there is yellow area, yellow color, which is 11.5 to 12.5 centimeter. This is MAM, which is where the child needs follow-up. And if it's green, more than 12.5 centimeter, it's normal. Okay, then this statement states how to measure mid-arm circumference. Usually they don't ask how to measure mid-arm circumference. So if you wish, you can read this paragraph. And then the skin fold thickness, about the skin fold thickness, it's useful for the long-term follow-up of children with obesity and other medical condition. Read properly this note because it is for long-term follow-up. The skin fold thickness is used for long-term follow-up in children with obesity and other medical condition. These are MCQ points. It's not a rapid screening method for undernutrition. It's a long-term follow-up method. Okay, and medical conditions like if there's a hormone deficiency, growth hormone, and if the child is on hormone replacement therapy, we can use skin fold thickness as long-term follow-up for the child. There are 4 common sites where we can measure the skin fold thickness, which can be asked in MCQs: bicep, tricep, subscapularia, suprailiac area. These areas are used to measure the skin fold thickness. They won't ask how to measure. They just ask the common sites or for which skin fold thickness is used for. A double layer of skin with subcutaneous tissues is chosen, and muscles underlying should be relaxed because if you, when measuring, if the muscles are contracted, you will be measuring the muscle thickness as well, which will give the wrong measurement. Use the Carpenden's caliber. This is instrument used. Caliber is used to measure the skin fold thickness. Triceps, biceps, subscapularia, suprailiac area. This note gives how to measure. If you want, you can read, but it won't be asked in the exams. Okay. Then the main area, the body proportions. This is important when investigating a child with short stature or long stature. And here, the body proportion, this is the complete height of the child. The nipple line, the pubic symphysis, where the leg breaks, where the leg starts, and this is a leg length. The terms, you should know the terms because some of the following slides will be using the terms. Okay. How to calculate the body ratio of the child? The height minus leg length. You know, this is a height, this is a leg length. You have to subtract it and have to divide by leg length. It means trunk plus head. This is a trunk. This is a trunk. This is a trunk and head. So trunk plus head is the height minus leg length over leg length. It means upper segment over lower segment. So this is a lower segment and this is the upper segment. Okay, lower segment and upper segment. These are MCQ points. At birth, this is an MCQ point. At birth, trunk plus head, it means the upper segment is longer than the legs at birth. So the body ratio will be 1.7:1. This is a MCQ point. So be clear. It falls by 0.1 every year under 10 years of age. So every year, this ratio falls by 0.1 under 10 years of age. At 8 years, the upper segment is to lower segment ratio will be 1:1. It means upper segment and lower segment are in equal length. Okay. At 10 year, the leg length equals trunk plus head equals a body ratio 1:1. Usually at 8 years, the ratio will be 1:1. So it will be asked in MCQs as at 5 years, the body ratio will be 1:1. That's wrong. At 8 to 10 years only, it will be 1:1 ratio, the upper segment and lower segment ratio. On an average, adult body ratio ranges from 1:1 to 0.1 is to 1:1 to 0.9 is to 1. Okay, this is a normal adult body ratio range. Upper segment is to lower segment ratio will be 1:1 to 0.1, 0.9 is to 1. The upper segment and lower segment ratio, if it is less than 0.8, it indicates Marfan syndrome. Or, quite happy they won't ask this, but you should know this can be MCQ, Marfan syndrome. Marfan syndrome, the upper segment and lower segment ratio will be less than 0.8. It means the lower segment will be lengthier than the upper segment. That's why Marfan syndrome, we will be discussing in our future sessions about Marfan syndrome, because it can be an MCQ question. If the upper segment lower segment ratio is more than 1.2, it means the upper segment is lengthier than the lower segment. It indicates rickets, Turner syndrome, achondroplasia-like illness. So for that, we should know upper segment, lower segment ratio and how to measure. These are MCQ points. After 8 years, 8 to 10 years, the lower body grows. I previously told you during adolescence, our trunk grows. Sorry, during puberty, our trunk grows, and before puberty, pre-puberty, our leg grows. Okay. Then in CHDR, about the Sri Lankan CHDR, it's used up to from birth till 19 years of age. We record the immunization status, the growth gain, and recordings and evaluations are done using CHDR. There are separate CHDR for girls and boys, pink for girls, blue for boys. Compare with population parameters, and there are standard charts, standard deviation charts. Standard deviation charts are the most used charts in Sri Lankan setup. This can be asked in MCQs or community medicine as well. The CHDR is important for community medicine as well. The type of chart that I previously said, the distance or velocity chart, they won't ask like this. There are weight for age charts, weight for height charts. I'll be discussing about all these things in the future session. Growth charts can be used to quickly diagnose even small fluctuations, and it's used for quick screening as well. Okay, then something about puberty. The puberty changes. It means they won't ask much about puberty, but precocious puberty and the normal puberty is asked in MCQs. Okay, in puberty for girls, there is an order. For girls and boys, there's an order. You should know the order. For in girls, this is the order. First is adrenarche, then thalake, which means breast budding, then early breast development, and pubarche. The final is the menarche, where the first menstruation occurs. This is the order. First, adrenarche occurs, where the adrenal hormones is secreted. Then the breast starts to bud, which is a thalake. Then the breast start to develop, and the pubic pubic hair grows, which is a pubarche, and ultimately menarche occurs, and the puberty stops at menarche, where the height gain minimal. After puberty, the height gain will be minimal. For boys, the first one is adrenarche, then the testicles start to grow, then penile growth happens, then the pubarche happens, the pubic hair and the axillary hair starts to occur, and ultimately that as a final stage, facial hair grows and shaving, and the ejaculation happens. This is the order in girls and boys. You should be thorough with the order, because there's a thing called precocious puberty, Central precocious puberty and peripheral precocious puberty, these are tested in MCQs as one or two stems sometimes, but not, these are not common MCQ. These are not common, but can be asked. Precocious puberty. What is precocious puberty? Precocious puberty means a child attains puberty before the normal age of onset of puberty. That differs from sex and from race to race. Okay, precocious puberty. There are two types. You don't need to know deep knowledge on precocious puberty. Sometimes it will be asking MCQ. For that purpose only, I am teaching this precocious puberty here. Okay, precocious puberty. There are two types: central and peripheral precocious puberty. Central precocious puberty means the hypothalamo-pituitary axis is activated and there will be normal order of puberty. This is enough. This is the MCQ point. The stem will occur in central precocious puberty. The normal order of puberty will be followed. That's a true statement. Which is a normal order of puberty for girls. First adrenarche, then thalarche, then pubarche, then menarche. For boys, first adrenarche, then testicular growth, then penile growth, then pubarche, then facial hair and ejaculation. So this is a normal pattern of order of puberty. For central precocious puberty, as this is precocious puberty, central precocious puberty is activated due to HPA axis activation. The normal order of puberty is followed. But in peripheral precocious puberty, this peripheral precocious puberty occurs only due to excess sex steroid production. It's not due to stimulation by hypothalamo-pituitary axis, is only due to sex steroid overproduction. There can be tumors, sex steroid secreting tumors, like that. There will be sex steroid overproduction, but the hypothalamo-pituitary axis won't be activated. So the order will differ. We can't see this puberty order in boys or girls if they have precocious puberty. Sorry, if they have peripheral precocious puberty. That's enough about precocious puberty. You don't need much knowledge for ERPM for exams. Okay. Then the paradoxiometer is used to find the testicular volume of the child or adults, whether testicles is grown adequate. Just familiar, be familiar with the name paradoxiometer. Okay, there are color codes, and the 4 to 12 size is the prepubertal size, and the red one is the adult size. If it is not in the red for the adult, the testicular volume is inadequate and there is a problem. Like that, if there's a problem, we screen using this occiometer and we treat them. We don't need about those problems for our level. It's postgraduate. Then the bone age, the skeletal maturation. Okay, this bone age, they won't ask much thing, but can be asked in MCQ as one or two steps. Bone age, skeletal maturation. There are the X-ray is taken and compared with set of standard X-ray for the age of the child. If there is any, these X-rays are not taken for all the children. If the child is if we are investigating a child for short stature or any bone disorders, we take the X-ray of the child and we compare that X-ray with the standard X-ray. It means at that age, how the X-ray should be. There are standard X-ray charts, but you don't need to know about those things. It gives an idea about the urgency, relaxation when managing a child with short stature, whether we have to treat the child urgently or we can treat the child with short stature and in a relaxing manner. That depends on the bone age. You don't need much thing about thing. Just know that bone age or X-ray of the hand, of the wrist and hand, that's enough. Is used when investigating short stage. That's enough. Okay. Then there are some terms, the definitions you should know. Chronological age, height or weight for age, skeletal age. What is chronological age? Chronological age means actual age from the birth taking measurement. If the child is born at 2012 and now it's 2025, then the chronological age is 13 years. This is just a mathematical calculation. But height or weight, but the skeletal age is not like that. Skeletal age means average age within the normal population to which the body development of the individual corresponds. It means the child is 13 years. Chronological age of the child is 13 years. But the bone, the skeleton of the child is matured matured as a 11-year-old child. It means the bones are matching. The bone maturation is like a 11-year-old child in a 13-year-old child. Then the skeletal age is 11 years. Like that. You don't need my deeper knowledge. Just for this, familiar with the terms chronological age and skeletal age. Then the height or weight for age. It means height, age at which the individual's height or weight would correspond with the 50th centile of the standard charts for the population of that sex. Example, if the child is 5 years and he's a boy and his height is 80 centimeters, just example like 80 centimeter and the but the standard 50th centile, it means the 50% of the population at 5 year, boy at 5 year would be 90 centimeter. The average height would be 90 centimeter. So this boy is shorter because the average height of a 5 year boy should be 90 centimeter. It's just an example, it's not a true value. But for this child, the child A, this child A is 80 centimeter at 5 years. So it's the height is not enough to that's the meaning of height for age. Or if it's a weight for age. If the child is 20 kg and he should be at 15 kg at 5 years, this is overweight. To compare, just to compare, the height or weight for age is taken. Okay. Then the relevant clinical observation in relation to growth disorders, we look for size at birth and antenatal factors, natural growth in infancy and early childhood, inheritance and family factors, nutritional status, gender state of health, hormonal status, psychological and physiological and emotional aspect of the growth. These things are taken under consideration when addressing any illness in children. And hormonal changes, many hormonal conditions lead to adverse growth. Usually weight acts in an opposite direction to height. Usually, if the height grows, the weight won't grow. The weight, it means weight won't increase. But once the height ceases, then the weight is the thing which keep on increasing. That's the thing. This is not a big deal. You all know. Endocrine process of short stature. I'll be discussing in detail about short stature. There I'll be discussing about how to investigate, because you can get short stature as your case if you're unlucky. And usually they don't give short stature for undergraduate level in the long cases. But in case if they are sure, if they don't have enough patients to give for the exam, they might give short stature uh, child, but it's very rare. They don't usually give, but they can give MCQ, so single best response on short stature. Endocrine cause of short stature, the growth hormone deficiency, thyroid deficiency, glucocorticoid excess, sex hormone deficiency, or delay production, short stage early. I'm just running because I'll be discussing in detail these things in future sessions. Excess or premature production, short stage ultimately, diabetes mellitus, and endocrine causes for tall stage, growth hormone excess, thyrotoxicosis, sex hormone, precocious, tall stage early, extreme delay, tall stage ultimately. Okay, then some MCQ points regarding birth weight up to 4 months. There will be 20 to 30 gram per day weight gain. These are the MCQ points. They appear again and again in MCQs. From 4 to 12 months of age, the child will gain 15 to 20 gram on average per day. And at 5 months of age, the weight will be double the birth weight. The weight will be double of the birth weight at 5 months of age. At 1 year of age, the weight will be triple of the birth weight. The child will get triple weight of the birth weight at 1 year of age. And at 2 years, it will be 4 times the birth weight. And at 5 years, it will be 10 times the birth weight. Okay, this is just the MCQ points you are usually given the true or false. Okay, then for the like that for height, at 5 months, 30% of adult height is achieved, and at 1 year, 50% of adult height is achieved, and at 5 year, the child will be 2 times the height of birth length. At 5 year, the child will be at 2 times the height of the birth length. Okay, at birth, if the child is 50 centimeter, at 5 years, the child will be 1 meter. That's the thing here. And for the OFC, at 3 months, it would be 2 centimeter, and at 6 months, 2 centimeter per month, like that. At 6 months, it would be 1 centimeter per month, and at 9 months, it will increase like 0.5 centimeter per month in this order. These are usually asked in MCQs. Okay, that's all about the growth of the children. The further classes will be conducted online, and if you need to clarify your doubts or if you need to register, please contact me on WhatsApp. This is my WhatsApp number. Okay, thank you for joining, and that's all for the day. I'll be doing MCQ sessions as well as history taking and case discussion in my future classes. Thank you.